Occupational English Test. Sample Test 2. Listening Test. This test has 3 parts. In each part, you'll hear a number of different extracts. At the start of each extract, you'll hear this sound. You'll have time to read the questions before you hear each extract, and you'll hear each extract once only. Complete your answers as you listen. At the end of the test, you'll have 2 minutes to check your answers. Part A. In this part of the test, you'll hear 2 different extracts. In each extract, a health professional is talking to a patient. For questions 1 to 24, complete the notes with information you hear. Now look at the notes for extract 1. Extract 1. Questions 1 to 12. You hear a gastroenterologist talking to a patient called Andrew Taylor. For questions 1 to 12, complete the notes with a word or short phrase. You now have 30 seconds to look at the notes.
Good morning, Mr. Taylor. Now, you've been referred to me because it's possible that you're suffering from irritable bowel syndrome or a related condition?
Yes, that's right.
Okay, could you start by giving me some background?
This has been going on for many years. After meals, I've always tended to get heartburn, but I found that pretty easy to deal with by taking antacids from the pharmacy. But a year ago, things suddenly got worse, and there were other problems I started to notice. The symptoms vary a lot, and they can be quite hard to describe exactly, but the main problem is bloating.
I see.
I need to tell you about some other things related to my stomach.
Mm-hmm.
Although this isn't something that happens every day, I've been suffering from constipation in the last month. In the past, I've had the opposite problem and would rush to the toilet several times a day. I just never know how I'm going to feel from one day to the next. It's the way the symptoms are so unpredictable that I hate. It's hard to plan my life.
Were there any other symptoms unrelated to your stomach and bowel?
Well, I have a skin condition that can flare up, and I know this could be related to irritable bowel syndrome.
Mm-hmm.
And the odd thing is that I often have migraines more or less at the same time as the stomach discomfort, and these can go on for days. It's strange, and I didn't at first think it was anything to do with my stomach problems.
Have you noticed anything that can intensify the symptoms in any way?
Well, I have a very demanding job as an accountant. I don't know whether this has a bearing on anything, but there's a chance I might lose my job in a reorganization of my department, so that's obviously something that's making me anxious. I don't know what's going to happen.
What's the worst effect the condition has on you?
The problem isn't just that it's nearly always on my mind unless there's some pretty big distraction, but also that it's so draining. What I mean is I often feel that I've got no energy at all. I just want to sit around and do nothing when I get home from work, to be honest. I go to bed tired, but I'm frustrated because I have insomnia much more than I ever did before. I wouldn't say I've been suffering from depression, but a condition like this can make you feel rather down.
Right. And I understand that you've investigated the possibility that your diet's responsible for your condition. Can you tell me about this?
I was told by a nutritionist I saw that people with irritable bowel syndrome often don't eat enough fiber. In my case, I don't feel that's an issue. I've followed the nutritionist's advice about taking more fluids during the day, especially water, and accept that in the past, maybe I didn't do that enough. It's hard to say whether that's made a difference, but possibly it's caused a slight improvement.
Uh-huh.
I'd read that dairy products can make things worse, so I tried cutting them out, but I wasn't convinced it made any difference. I've cut back on caffeine, though not much, actually. I also paid for extensive food allergy tests, but they didn't show anything major, so that's not an area my doctor thought was worth investigating further.
What medications have you tried?
Well, I took something called an antispasmodic,
Yep.
which my GP says helps to relax the muscular contractions which move food through the gut, but to be honest, I don't think it made much difference in my case.
Have you taken anything else?
Well, I've been given antidepressants, and I'm giving them a go. I wasn't sure I completely understood the reasons.
Okay, well, a drug like that targets the signals being sent to and from the nerves in the digestive system. It has a calming effect on the muscles there.
Mm-hmm.
Do you find that this drug was effective?
Yes, I'd say it was on the whole.
Extract 2. Questions 13 to 24. You hear a hospital neurologist talking to a new patient called Kathy Tanner. For questions 13 to 24, complete the notes with a word or short phrase. You now have 30 seconds to look at the notes.
Hello, Mrs. Tanner. Pleased to meet you.
Hello.
Do you mind if we start off by getting some background to your condition? Just in your own words, could you talk me through the reason you're here and how it all started?
Oh, please, call me Kathy.
Right.
So, until 2 years ago, my husband was in the army.
Right.
We lived off base, and I had a job which involved a lot of driving.
Mm-hmm.
Whenever I was in the car, I noticed that my neck would get pretty stiff at times.
Right.
It was hard to turn my head. To cut a long story short, when my husband left the army, we moved to a new house. My neck pain was still a problem, so I decided to visit an osteopath.
Right.
He tried to fix the problem by a neck adjustment, but actually it just made things worse.
Oh, dear.
I found I was losing flexibility in my neck. I began to use a heat pad, which did help at first.
Good, but so not for long?
No. About a month or two on, I started to get this sort of feeling that something was pulling my head over towards my right shoulder.
Right.
It was painful and embarrassing because I couldn't keep my head straight.
Of course.
I'd managed to hide it from everyone around me until then. About this time, one of the doctors I'd seen thought physiotherapy might help and sent me to a nearby clinic.
Mm-hmm.
So I started going in regularly for treatments. And one day, the head of the clinic looked at me while the therapist was trying to position my neck and whatever. And he said, "You know what your problem is, don't you?" And I replied that I didn't. And he told me that I had spasmodic torticollis, and I had no idea what that was.
So what happened then?
So he says, "Oh, it's untreatable. You just have to learn to live with it." I went home in pain, feeling depressed and hopeless.
Yes, of course.
He was just so unsympathetic and unhelpful.
Well, I'm sorry to hear this.
Thanks. So my diagnosis of spasmodic torticollis was in June. So I began to research, what I could do. I tried chiropractic treatment until December. It cost a fortune, but did no good.
Oh, dear.
The pulling and pain continued to increase. I saw a couple of neurologists and I was put on a drug called baclofen, but it really didn't make any difference.
Yes, that wouldn't do much for your condition.
Oh, right. Anyway, the one really good thing I did at that time was to join a support group for spasmodic torticollis patients, so at least I knew I wasn't alone with the condition. But mostly, I just sat at home a lot. In order to get a bit of pain relief, I got myself an orthopaedic chair, and that did give me some support.
Right.
In November, I saw something in a magazine in the medical section. It mentioned some new treatments being done at the university hospital to treat things like spasmodic torticollis with Botox. We mentioned this to our GP, got a referral, and in December, I had the first injection in my neck.
And how did the treatment go?
Well, the injections really helped the pain, you know. My head returned to almost a normal position.
Right.
It did give me a few problems, like problems swallowing, but that was okay. I thought I'd received a miracle cure. I was devastated when everything started to come back like before, and I went back to the hospital in May. At this time, the results weren't quite as good. Even though they'd upped the dosages, I ended up having 9 lots of injections, plus the, various oral medications. So I can't remember what they were.
No, it doesn't matter.
But nothing really made much difference. I just got more and more confused, and loss of memory became a problem too. Just for pain relief, they ended up giving me a pump so I could give myself morphine. Finally, I saw something in my ST support group's magazine about a relatively new type of surgery being done by a local neurologist, and that would be you. So here I am.
And we will do our best to help you. Now, just a few more questions.
That is the end of Part A. Now look at Part B. Part B. In this part of the test, you'll hear 6 different extracts. In each extract, you'll hear people talking in a different healthcare setting. For questions 25 to 30, choose the answer A, B, or C, which fits best according to what you hear. You'll have time to read each question before you listen. Complete your answers as you listen. Now look at question 25. You hear an optometrist talking to a patient who's trying contact lenses for the first time. Now read the question.
Now, you've had the lenses in for a few minutes. How are they feeling?
Not bad. I thought I'd feel them actually touching my eyes, that they'd be sore or prickly, but I can't feel much at all. My eyes do feel a bit watery, though.
It's okay. You've just used too much solution. Now, in a few minutes, I'll get you to try taking them out and inserting them again by yourself.
I had no trouble taking them out earlier, but I'm not confident about putting them in. I worry I'll press too hard.
That's unlikely to happen.
Things look rather distorted, though. I mean, I can't make out the letters on that chart.
Any of them?
Those lower down.
Let's give things another minute to settle down.
Question 26. You hear a nurse asking a colleague for help with a patient. Now read the question.
Kathy, could you help me with the patient in bed 103? The woman who had surgery 2 days ago.
Oh, yes, she's due for discharge today, isn't she? Does her pain relief need topping up again?
I thought she wasn't very comfortable this morning.
Oh, she's on a reasonably low dose, but she's coping. She needs her chest drains removing, though, and she's got herself into a bit of a state.
Ah, well, that's a two-person job anyway, so I'll come with you. Has the consultant seen her? I know there was some concern yesterday about her condition and the level of the fluids draining into the bags.
Oh, he's cleared her for removal of them today, but I think some reassurance might be needed first.
Right. I might just check her analgesia and give her more before we go ahead.
Okay.
Question 27. You hear a senior nurse talking about a new initiative that has been introduced on her ward. Now read the question.
One of our key priorities is improving communications between staff, patients and patients' families. We recently introduced a scheme called Dear Doctor, which involves giving each patient a card where they can make a note of any questions or concerns that they themselves have. They can also talk to their families during visiting time, or even on the phone, and see if there's anything else they'd like to add. The cards are then collected and given to the doctor before the ward round. We're really pleased with the response. Patients used to say that they only thought of the things they felt they needed to discuss when it was too late, so the cards give them a better chance to bring up whatever's on their minds. In fact, it's been so successful that we're going to roll it out on all wards in the hospital.
Question 28. You hear two radiologists talking about the type of scan to be given to a patient. Now read the question.
I've just had a phone call from emergency. They have an 11-year-old boy with right lower quadrant abdominal pain. They're concerned about appendicitis, and they'd like to order an abdominal CT for him.
Do you think that's a good idea?
I was thinking maybe we should recommend an abdominal ultrasound, because then we can spare him the radiation.
Is there any concern in this case around using ultrasound instead of CT? Accuracy, for example.
The sensitivity is slightly less than the CT, but the specificity is almost the same, so I think we can rely on the results.
Okay. It means we can avoid the child being subject to contrast exposure as well. But what would we do if the ultrasound doesn't answer the question?
If we can't visualise the complete appendix, then we can recommend an abdominal CT.
Okay, we have a plan. Call them back and let them know.
Question 29. You hear part of a surgical team's briefing. Now read the question.
OK, next is Mr Malloy's repeat laparotomy. Any anaesthesia issues?
We don't expect any particular problems. He's relatively fit and well, except for his epilepsy, which is under good control. His BMI is 35.
Will we need the obesity bed?
It shouldn't be an issue.
And what about the epilepsy post-operative management?
He's taking his oral medications, and we can use an IV if necessary.
I know he was in a lot of discomfort after his last surgery, and this time he's going to need a larger midline incision. It may be worth thinking about an epidural. He's certainly at the extremely low edge in terms of pain threshold.
Question 30. You hear a senior research associate talking about a proposal to introduce interprofessional primary healthcare teams. Now read the question.
We're looking at opportunities to improve the effectiveness of health and healthcare systems here in Canada. One of the interventions we're looking at is interprofessional primary care teams, groups of professionals working together collaboratively to provide services including healthcare, social services, and advice to patients within the primary care setting. There's evidence that teams like these can improve chronic disease outcomes, including diabetes, hypertension, and heart disease, as well as mental health problems. There's also evidence that improvements can be made in terms of both access to and coordination of care. Now, the extent to which these teams could affect the costs of healthcare in such areas isn't quite clear within the evidence, but the work we're doing aims to address such issues while looking at the challenges of implementation and evaluation.
That is the end of Part B. Now look at Part C. Part C. In this part of the test, you'll hear 2 different extracts. In each extract, you'll hear health professionals talking about aspects of their work. For questions 31 to 42, choose the answer A, B, or C, which fits best according to what you hear. Complete your answers as you listen. Now look at Extract 1. Extract 1, questions 31 to 36. You hear a presentation by a specialist cancer nurse called Sandra Morton, who's talking about her work with prostate cancer patients, including a man called Harry. You now have 90 seconds to read questions 31 to 36.
My name's Sandra Morton and I'm a specialist cancer nurse, helping cancer patients deal with their diagnosis and treatment. I'd like to tell you about the type of work I do, and particularly about one of my patients, recently diagnosed with prostate cancer. Let's call him Harry, to illustrate the sort of things I get involved with. Now, before we get on to Harry, I'll give you a bit of background. Clearly, my job covers many aspects of patient care, but what's the priority? Firstly, prostate cancer is in fact the most common cancer in men in the UK, with over 40,000 new cases diagnosed every year. That's a staggering number. One problem is that this type of cancer actually develops very slowly, so there may be absolutely no sign that you have it for years. So, if we're going to reduce the number of cases, it's vital that people like me get the word out to as many men as possible, that we tell them how to spot the signs of prostate cancer, like an increased need to urinate or straining while urinating. Unfortunately, the cancer can be at an advanced stage by the time patients come in for tests, at which point the available treatments are far less effective. So, let me tell you a bit more about my patient Harry. Like many middle-aged men, Harry was offered a routine health check at his local doctor's surgery. As far as he was concerned, he had no particular health problems or obvious symptoms at the time, and so he almost ignored the invitation. But he'd promised his family he'd look after himself. His wife had died of ovarian cancer some years before, so he felt obliged to go. It was during his appointment that, based on a few symptoms he mentioned, Harry's doctor decided that he'd need further investigation for prostate cancer and referred him to a specialist clinic at the hospital. Harry's trip to the clinic started with a routine blood test, which initially showed a slightly low haemoglobin level. A further test then revealed that his PSA, the prostate-specific antigen, was high at 20. He then saw a urology consultant who conducted a digital rectal examination and biopsy. A procedure that I always try to explain to patients may be uncomfortable, but is entirely necessary. In fact, though, Harry said the 3-week interval between having a biopsy taken and hearing the outcome was far more of an ordeal. Harry told me that when he went to see the consultant to get his results, he immediately sensed he was in trouble. Although the consultant was very considerate in delivering the news, unfortunately the indications were that Harry did indeed have prostate cancer. He was assured that the cancer was low-grade and not aggressive. Harry had suspected the worst, and though he tried to prepare himself for it by doing some online research, finally hearing that confirmation was still a shock. In fact, the very mention of the word sent Harry into panic, which was very unlike him. So at the time I first met him, he was very vulnerable and grateful to have someone to talk to. Of course, the response to the illness amongst prostate cancer patients like Harry can vary enormously. I've dealt with some men, for example, who haven't really realised the importance of keeping up their medication because they've felt relatively well, especially if they've been experiencing unwanted side effects. Unfortunately, though, any break gives the disease the perfect opportunity to spread into the bones, making it much more difficult to treat and a successful outcome less likely. And some treatments do cause some unfortunate effects, such as erectile dysfunction, which some men really feel uncomfortable discussing, because it's a sensitive issue. Other patients have mentioned that even though they've been given a lot of help, it's still difficult to weigh up the pros and cons of the various treatment options they're offered, from ultrasound or radiotherapy right through to radical prostatectomy. So responses like these need to be taken into account by specialist nurses when talking to patients. For me, these factors really underline the importance of the community follow-up clinics we have in my area, which address many of these issues in the provision of healthcare for cancer patients. Staff at these clinics see patients during their recovery and only send them back to hospital for treatment if they develop significant new symptoms. Seeing patients in the clinics means that staff get to know each patient and build a relationship with them, which enables nurses like me to dispense advice and answer questions. And although we have no firm evidence, staff feel that's far more beneficial to patients than attending a large hospital clinic. So we're hoping more clinics like these can become available.
Now look at Extract 2. Extract 2, questions 37 to 42. You hear a neurologist called Dr. Frank Madison giving a presentation about the overuse of painkillers. You now have 90 seconds to read questions 37 to 42.
I'm Dr. Frank Madison, and I'm a neurologist with a special interest in the overuse of painkillers, particularly of opioids, something experts are now calling the silent epidemic. Now, we've all seen the stereotypical images of addicts hooked on recreational drugs, but addiction to painkillers like opioids has a much less familiar public face. From what I've seen, one reason for this is that the range of people affected makes them less easy to pigeonhole. I mean, there's no typical age, social class, and so on. And of course, most people seeking help for opioid overuse were initially prescribed the medication by their own doctors for pain relief. This highlights a major part of the problem. Physicians often pay little attention to the possible risk of addiction. They need to look carefully at patients' personal histories and assess the risk, considering things like depression and anxiety disorders, before prescribing opioids. In recent years, there's been a dramatic increase in opioid prescriptions. I see a pattern not just of GPs overprescribing, but of GPs inappropriately prescribing. Sure, people want their pain relieved immediately, that's understandable, but proper pain management requires lengthy face-to-face input, which time pressures don't allow, so easier alternatives have become the default option. What's more, although opioids can provide effective relief in the short term, they shouldn't be the automatic first-line therapy. Many alternatives do exist, and they're no more costly. People generally think of pain as a direct symptom of a problem in the affected area. But pain is an extremely complex subject, and it's one that used to be underrepresented in medical education. Thankfully, that's no longer the case, and doctors now realise that when a patient complains of acute back pain, that pain may not be due to a clear and treatable disease, but that such pain often presents in people with other medical problems, and these need investigation. Although there are distinct types of physical pain, all too often, I see sufferers lumped together in one category, which means that unfortunately, not all treatments are going to work equally well. For example, we first need to know, is the pain caused by inflammation as opposed to nerve damage? Establishing this makes initial mistreatment far less likely, meaning that treatment is more effective and the risks of long-term problems are reduced. But it's not just opioids we need to watch. Patients often self-treat with readily available painkillers like paracetamol. And while such drugs play an essential role in pain management, people still need to know more about them. We've been pretty successful in publicising the dangers of accidental overdose, and clear information's given about the effects of taking these drugs long-term, so public awareness about increased tolerance levels is also gradually improving. Many doctors also now actively warn patients about the spiral of taking higher and higher doses for pain relief. Worryingly, though, I've seen cases where people on drug regimes for other conditions inadvertently take painkillers which add a potentially hazardous ingredient to the mix already in their system. This is something which needs urgent attention. I'd like now to talk about an osteoarthritic patient who was referred to me, a 30-year-old woman, let's call her Anne, suffering from sarcoidosis, an autoimmune disease leading to chronic organ inflammation. She was prescribed various drugs, but though the disease was soon brought under control, the pain lingered, with Anne gradually becoming dependent on prescription opioids. Typically, she was terrified of stopping them, yet the more she took, the worse she felt. The thing is, her prescription would have been ideal for short-term pain, like that following surgery, but should never have been given for the chronic pain she was experiencing. And we all know that living with medication dependency has devastating consequences, not only on social well-being, but also on ability to function professionally, as was the case for Anne. She eventually went on long-term sick leave, as often happens in such cases. Thankfully, Anne's now much better. Having recognised her dependence, and with the necessary support, tools and techniques, she's now off painkillers. The crucial thing is to prevent dependence in the first place. Anne's GP prescribed opioids in good faith, aiming at pain reduction, but failed to set an end date for these. He hadn't anticipated the possibility of eventual drug reliance, this being new territory to him. Anne couldn't hide the visible results of the quantities she was eventually taking, so her GP questioned her about intake. She reluctantly admitted supplementing her prescription from sources like friends and family, something her GP had suspected but hadn't investigated. Anne now realises that drugs weren't fixing her problem, and though withdrawal took several tough months, her determination to succeed has paid dividends.
That is the end of Part C.
Extract 1. Questions 1 to 12. You hear a primary care doctor talking to a patient called Hayley Dove. For questions 1 to 12, complete the notes with a word or short phrase that you hear. You now have 30 seconds to look at the notes.
So, Mrs. Dove, I have your notes here, but it would be good to hear things from your perspective. How all this started, what treatments you've had, anything you think I should be aware of.
Well, where to begin? I should explain that I'd been suffering with endometriosis for quite a long time, ever since my son was born, actually, and he's at university now. So I was used to a certain level of discomfort. You know, feeling bloated a lot of the time, getting the occasional bouts of nausea and feeling quite a bit of fatigue.
Right.
Anyway, after a while, I also started to get pain in my lower back, and that gradually got worse and worse. I was working as a preschool teacher in those days and had a young family of my own. It was a tough time. In the end, I had to give up my job. Anyway, to cut a long story short, I was eventually diagnosed with cervical cancer. I was fairly lucky, I guess. It hadn't advanced too much, and I was advised to have a hysterectomy. Although I was out of action for a while, it all went relatively smoothly, and of course it also sorted out my other problems. So for a while I was relatively well. My kids were at school by this time, so I was able to start my own business, working online as a recruitment consultant. I'd put both illnesses behind me, and I was feeling very positive.
But then you started to develop other symptoms.
That's right. Those feelings of fatigue started coming back. I'd find I was exhausted after a full day of online meetings. If I did have to go anywhere and do anything, like attend the occasional conference, especially if it involved driving any distance, that would just wipe me out. So something obviously wasn't right. Anyway, I went to see the doctor, and he said that it sounded like I might have iron deficiency anemia, and he did some blood tests. But when the results came back, I was really surprised to find I actually had iron overload, and the next step was to test for hemochromatosis, and of course that came back positive. The first thing the doctor asked was whether anyone else in the family had ever had it, because it can be genetic. Anyway, I didn't know for sure because I was adopted as a baby, and I'd only just recently traced my birth mother and started to get to know her. Anyway, she was able to confirm that some cousins, whom I'd never met, had indeed got the same thing.
I see. So, have you been having treatment?
Yes, I was told that the only option was venesection. That came as a bit of a shock, and I had it every week initially, then once a month, and I've been going every 3 months for some years now. I mean, it's fine. It hurt a bit at first, but I'm left with quite a bit of scarring on the arm where the needle goes in, but it's something I can live with. For the last few years, I've been back to my usual energetic self.
So, what brings you here today?
Well, I've started to develop some other problems, and I'd just like to have them checked out. I mean, I'm not getting any younger, so these could be completely unconnected with the blood problem. Anyway, the first thing is that I've started to get a bit of stiffness in my joints. It's particularly noticeable in my fingers, but I think it's there in my knees too. Then I also seem to be getting more thirsty than usual, and it doesn't seem to be related to how much I drink. And the other thing is that I get a bit short of breath sometimes, even when I haven't been doing anything particularly strenuous, just walking the dog or washing the car, and it suddenly comes on. And none of these things is a big deal, but I've just noticed the change.
Sure. I'll ask you a bit more about those symptoms in a moment, but what I'd like to do first is have a listen to your chest.
You hear a physiotherapist talking to a patient called Marvin Cheney. For questions 13 to 24, complete the notes with a word or short phrase that you hear. You now have 30 seconds to look at the notes.
So, Marvin, I understand you've been referred to me because you are experiencing some symptoms of long COVID, and your doctor suggested that some physiotherapy could help.
That's right.
I've got your notes here, but as we haven't met before, could you just run through for me how all this started, any treatment you've had, and anything else you feel I should be aware of?
Yeah, sure. It all started when I caught COVID-19. I mean, I hadn't been vaccinated, so maybe it was worse than it might have been, but who knows. Anyway, I had it pretty bad, but not bad enough to go to the hospital. I had the usual flu-like symptoms that turned into a dry cough. It completely wiped me out. I never felt so sick in my whole life, but I got over it, and in time, the symptoms pretty much disappeared. I was coughing for about a month, but otherwise, I thought I'd beaten it.
I see. So when did the long COVID symptoms start?
I'd say like 6 weeks afterwards. The cough had gone, but I still wasn't feeling 100%.
Right.
Looking back, the whole experience had kind of sapped my energy. I didn't feel like going to the gym like I used to do before because I was getting out of breath just doing ordinary things like carrying groceries. Then other stuff started happening. I wasn't sleeping properly, so I was tired pretty much the whole time. Like, I'd wake up with a headache, and it would go on all day, just get worse and worse, and that's when the other symptoms would kick in.
Okay.
Like, my brain would go kind of fuzzy, so I couldn't focus on anything properly, and I'd start to get this thing where I couldn't remember stuff. Like, words would be on the tip of my tongue, but just wouldn't come out. I mean, that was weird. Anyway, at first, I didn't make the connection with COVID. I assumed something else was going on. And when I started to get palpitations and chest pains, I went to see the doctor because I thought it must be a problem with my heart.
Yes, of course. So, did you get a diagnosis and treatment then?
Well, I had all kinds of tests, including an ECG, and they put me on a heart monitor for 5 days. And that's when they said it was arrhythmia, and they put me on beta blockers. And I did start to feel better, like almost immediately. And they also said that my vitamin D levels were low and that I should take supplements for that. And that helped too.
Okay.
And they said this was all down to long COVID, apparently. And I'm still getting some strange symptoms despite the medications, and that's why I've come to see you.
Okay. Tell me about those and how I might be able to help you.
Well, basically, if I overdo things, like if I try to do too much or if I get anxious, then I start getting the symptoms again. Mostly fatigue, but also a certain amount of joint pain, often in my hips, but it can also affect my ankles, even my feet sometimes.
Right.
It's like a dull ache, and it seems to be related to the fatigue. I also get a certain amount of numbness in my fingers, which is a bit worrying. I mean, I still do quite a bit of exercise, but I mostly do gentle stuff. Like, I've always done yoga, but I've also recently started doing Tai Chi, and that seems right for me. I would like to start going to the gym again, though I'm aware that I shouldn't do anything too strenuous. So I was hoping to get some guidance on strength-building exercises. I mean, should I be using things like resistance bands or even trying light weights? It would be really good to do things like that, but I feel I need to do it under someone's guidance at the moment.
Yes, of course. Well, thank you for all that background, Marvin. That's really given me a good idea of what we need to do. I'd like to start by...
Now look at question 25. You hear a hospital nurse talking to a patient. Now read the question.
Hi there, I'm Dory. I'll be your nurse while you're here at the rehabilitation centre. How are you feeling today?
Okay, just a bit tired after the surgery.
That's understandable. I need to go over the falls policy with you. As you know, falls can be a significant risk for patients, especially after hip replacement surgery like yours. It's important to take precautions to minimise the risk of injury. Are you familiar with the policy?
Well, I know to use the call bell if I need help getting out of bed and to use my frame when I'm walking. I was told to keep my personal belongings within reach and report any spills immediately. What worries me is that I keep coming over dizzy when I go to stand up. I guess I should just keep still and wait till it passes.
You certainly shouldn't try to move. And press your call button if you can, and we'll be straight with you.
Question 26. You hear two community nurses conducting a patient handover. Now read the question.
My main concern is Pavel. He's an 85-year-old male who has a diagnosis of vascular dementia. He lives at home with his wife, Maria. She has her own health problems, but generally seems to manage well, and there's a daughter living locally.
Okay.
Pavel had a significant ischemic stroke 5 years ago, and since then has presented with memory problems and occasional non-distressing hallucinations. He has some expressive dysphasia and dribbling of saliva, for which a speech pathologist offered conservative advice. He also has COPD that he self-manages with inhalers. He was diagnosed with a hydrocele, which presented shortly after his dementia diagnosis and causes him a bit of distress. He keeps forgetting it's there, so you may need to go over with him how to avoid discomfort when sitting down or using the bathroom.
Okay.
Question 27. You hear the beginning of a training session for nurses about to start work on a paediatric ward. Now read the question.
Today, we're talking about how, as nurses, we can support the best resuscitation outcomes in our patients. Now, unlike adult cardiorespiratory arrest, that's mostly caused by ventricular fibrillation, most pediatric cardiorespiratory arrests are secondary arrests caused by hypoxia as a direct result of underlying illness or injury. So, when a child's condition is deteriorating, it's vital to provide airway, breathing, and cardiac support to prevent progression to cardiorespiratory arrest. Having a thorough understanding and knowledge of the equipment on the paediatric emergency trolley means you can select the equipment you need to manage the deteriorating patient in an emergency situation. So that's what we're focusing on in this session. The equipment is stored in an emergency trolley which has specific equipment for either airways, breathing, circulation, or disability stored in each of its 4 drawers.
Question 28. You hear an occupational therapist briefing a trainee about a home visit that is going to observe her making. Now read the question.
OK, so the first patient today is Mrs. Olvera. She's 86 years old and recently widowed. She's finding living alone rather challenging and her function has declined, leaving her with increased anxiety.
I see.
Her son's staying temporarily, but he's due to go home next week. So what we're doing today is trying to increase her confidence when preparing their lunch. We'll get her to gather all the items she needs and set the table, and then supervise her heating the meal, giving as much reassurance as we can.
I see.
If that goes well, then we can move on to the stair lift, because she needs to access upstairs and she's particularly anxious about the controls. This is where the son's rather inclined to take over. That's understandable, but we need him to see that it's better to guide and support her rather than trying to do things for her. But we may not get to that today.
Sure.
Question 29. You hear a hospital pharmacist talking to a patient. Now read the question.
So, how are you getting on with the omeprazole you're taking for your acid reflux?
Well, there's no doubt it does the job. I've hardly been woken up by the reflux at all, unless I forget to take it, of course. It's meant to be an hour before dinner. I don't always manage to stick to that.
Well, to get the full benefit, you do need to take it as directed.
I realise that. The thing that's bothering me actually is that I've read how it can lead to other problems eventually if you're on it too long, like bone fractures, kidney disease, even infections. I'm not keen on that idea.
Well, the benefits definitely outweigh any risks, as long as you don't exceed the recommended dose.
I think I'm more inclined to try and wean myself off it if I can.
I wouldn't advise that, actually. We'll monitor you and adjust it as needed.
Question 30. You hear a primary care doctor talking to a patient. Now read the question.
So, how can I help you?
My big toe's very sore, especially if I walk any distance or put my weight on it. I've been taking painkillers and using an ice pack, but it's not getting any better.
I see. Have you ever had any problems like this before?
Well, yes, I had gout a few years ago, but not in this toe. My doctor at the time suggested losing weight and adjusting my diet, which I did, and it cleared up without too much trouble.
Perhaps you've knocked it somehow?
Well, I did trip over a curb last week. It hurt a bit at the time, then I forgot about it. But a couple of days later, this started. Do you think that it set off the gout again somehow?
It's possible. Is it okay if I examine your toe?
Yes, of course.
You hear Dr. Pietro Everall giving a presentation on the subject of cholesterol. You now have 90 seconds to read questions 31 to 36.
My name's Pietro Everall, and my presentation is about cholesterol. And it's a fascinating, if rather complex, topic. And that probably accounts for why, amongst our patients, there's a lot of misunderstanding about the role of cholesterol and about when and why it represents a health issue. To my mind, this largely results from the rather loose use of the word, particularly by journalists and others, that leads to cholesterol being perceived as a bad thing in the patient's mind. As doctors and nurses, we have to find a way of telling our patients exactly what cholesterol is, in simple terms, and why it's important, and that means going back to the basic science. It's long been established that cholesterol, by helping to move fat around the body, taking it to the organs that need it, is essential for health, that without it, the body wouldn't be able to function. But when it becomes oxidized or damaged, cholesterol can contribute to the buildup of plaque in the arteries, increasing the risk of heart disease and stroke. So, we often talk to patients about good and bad cholesterol as a way of avoiding more technical definitions. Because there are different types of cholesterol particles. For example, low-density lipoproteins, often called LDL particles, are more likely to become oxidized and contribute to buildup of plaque, whereas larger, high-density or HDL particles are less likely to. So the labels good and bad, although simplistic, can help patients to see that we need to look at the whole picture, rather than just focusing on the total amount of cholesterol in the body, and also that advanced lipid testing is important because it gives us information about the different types of cholesterol particles and helps us identify patients needing treatment. But patients can be reluctant to engage with the issue of cholesterol. As we know, when it comes to treatment, early intervention is key, but patients don't always see this. One thing they find hard to grasp is that although they feel perfectly fit and healthy, high cholesterol can be building up inside blood vessel walls, narrowing them and reducing blood flow to the heart and brain, thereby increasing the risk of cardiovascular problems. That's why it's imperative for those in high-risk groups, essentially men over 45 and women over 55, to have regular blood tests to measure not just the total amount of cholesterol in the blood, but also levels of HDL, LDL and triglycerides, a fatty substance similar to bad cholesterol. And preventive medicine has a key role to play here. It's estimated that 60% of adults in high-risk age groups have raised cholesterol levels, and whilst genetic factors are sometimes in play, in most cases it's just the result of poor diet, obesity and lack of exercise, often reflecting the habits of a lifetime. So it's clear that we should be talking to younger patients about these issues too, and not just about diet and exercise either. There's research to suggest a link between stressful situations and how the body metabolizes fat. And that's in addition to the fact that stressed out people are more likely to smoke or have poor diets. So we should be underlining the need for a good work-life balance, for taking regular breaks and managing stress levels in the workplace long before patients enter the high-risk demographic. Traditionally, statins have been the most commonly prescribed medication for high cholesterol, and that generally means a daily dose taken orally for life. Statins lower LDL levels by slowing down the production of cholesterol in the liver. But a new drug called inclisiran works in a different way, targeting a gene that produces the protein PCSK9 to encourage the liver to absorb more bad cholesterol from the blood and break it down. As well as only requiring twice-yearly injections, making it much more convenient, the drug has fewer side effects, which, with statins, can include headaches and digestive problems. And studies show that treatment can reduce cholesterol by up to 50% in as little as 2 weeks. The drug's an example of what's called gene silencing. This is a unique mechanism that aims to disrupt the delivery of messages sent out by a gene that can cause illness, in the case of cholesterol, of the protein PCSK9. It doesn't touch the gene itself, an idea about which people do get nervous, and it bears no relation to things like gene editing, which also gets a bad press. The first such medication was a drug called Partizan that was licensed in 2019 to treat amyloidosis, and work is continuing on similar drugs that could treat things like Huntington's disease and preeclampsia. So in rolling out these injections to control cholesterol, we could be looking at the future of how all disease will be treated.
You hear an interview with a nurse called Leanne Haydock, who's talking about the issues involved in caring for obese or plus-size patients. You now have 90 seconds to read questions 37 to 42.
Today I'm talking to Leanne Haydock, a nurse with a special interest in the care of obese or plus-size patients. This is a real issue, isn't it, Leanne?
It is. The number of people carrying extra weight's been on the increase for some time. Obesity now affects around 1 in 4 adults in many Western countries, and it's known to be associated with increased risk of health conditions including type 2 diabetes, heart disease and stroke. But we shouldn't forget that the reasons for this increase are complex and often very challenging to understand. So addressing the root causes of the issue isn't the job of health professionals on the front line. Our job is to offer optimal care for these patients. And this means moving away from treating them as the exception to the rule, towards making them an integral part of what we do. I'm committed to that idea, but making it happen is easier said than done. It means a major shift in both attitudes and policies.
So what sort of attitudes towards plus-size patients have you come across?
One issue they face is the very common misconception that they're somehow responsible for their size, that it's simply a lifestyle choice. Even amongst health professionals, you'll get comments like, if they just lose weight, there wouldn't be an issue. This is so unfair because the reasons for obesity are enormously varied and complex, and I find comments like this very disheartening. I can understand that it's human nature to judge other people, to wonder why someone's become so overweight, to feel that it was somehow avoidable, but none of that justifies offering this patient group anything but the best possible standards of care, and that's what we should be aiming for.
But treating them must involve adopting a different approach sometimes.
Yes, but we need to focus on finding the best flexible approach that works for all patients. Get away from the idea that the plus-size patient is unsuitable for the setup we have in place. For example, it's the bed that's not suitable, not the patient who's too big to fit the bed. The notion of an average-size patient lying on a bed that isn't large enough, or being expected to use a commode that's too small for them, would be rightly regarded as inappropriate and undignified care. Ensuring that plus-size patients have appropriate equipment and that everyone knows how to use it is crucial.
And specialised equipment is available?
It's not that the equipment doesn't exist. There are specialist versions of most things, from hoists to mobility aids to commodes. The problem is getting hold of these things in many hospitals. That's partly because traditionally it hasn't been a priority for funding, and policies haven't kept pace with changes in society. But there are other issues here too. What really causes headaches is where you can order, say, a large bed, but the doors, corridors and stairs aren't wide enough to get it to you. Many older hospitals weren't designed with the needs of plus-size people in mind. So even if you get the large bed in place, is there enough space for patients and staff to move around easily, and so on?
But clinicians have other concerns, especially around safety issues, don't they?
Well, yes. For nurses in particular, one major concern involves moving and manual handling. If a patient's carrying a lot of excess weight, then more staff may be needed, and there's a greater risk of somebody getting hurt. Turning a patient in bed, transferring to a chair, supporting a limb, all become much more complex and sometimes daunting if the patient is plus size. Clearly, what's needed is a risk assessment, and information sharing is central to that. Being able to map out the patient journey and anticipate needs helps us provide the best care. So, for a routine admission, nurses should know how the patient's going to arrive, where they're going to sit, etc., and not be suddenly confronted by someone whose needs can't be met.
And what about the human dimension?
Well, a key part of optimising care for these patients is avoiding assumptions about their capabilities. Nurses should have conversations with patients, ask how they normally handle specific tasks at home, and see if this can be adapted into the healthcare setting. As one patient put it, "We know we're large. We might be living under some delusion about the extent of it or the damage that it may do to our long-term health, but we're not unaware. So although the subject needs to be handled with sensitivity, tact and dignity, it's relevant to care that it happens. And another important thing to remember is that the patient may feel worried on your behalf and be keen to work with you to reduce any risk.